And Cosmas is a dedicated lab professional with very many years of solid foundation in diagnostic laboratory medicine. And we know that we are going to learn and just share. So welcome, Cosmas, if you can hear us. And you can just unmute, say hi, and then you can just proceed.
Okay, greetings everyone. I think maybe if you can confirm that you can hear me.
Yes, we can hear you.
All right, thanks so much for also having me on board today as we look forward to discussing issues to do with liver function tests. And my name is Cosmas Barasa, as you had been informed, and we are going to handle this vital topic, which I know that all of us have been able to come across it, or we are doing it in our benches to highlight few issues that we may feel necessary to know regarding liver function tests, interpretations, and how they're supposed to be, so that we may release reports that are going to make sense to our patients and our referring clients, doctors, or whoever that has sent the samples to us. And it will be I hope that we are going to learn something at the end of the day. So the topic is understanding liver function tests, which is a guide for laboratory and clinical practice. And my name is Cosmas, as highlighted there. So the objectives for this presentation will be to highlight the anatomy of the liver, and then also highlight the physiology or the functions of the liver. We are also going to classify liver function tests, and then look at the clinical utility of liver function tests and how to interpret them, which tests to do at what particular time, and to help clients get the most out of the laboratory medicine practices that we're doing in our country. Now, on the anatomy of the liver, this is the human liver. If I can be able to point it out. And it's a moment, I'm looking for the pen, the pointer. All right, this is the human liver. And we can see that's made up of two regions. And this one has been cut in the middle. And we have the hepatic portal, the hepatic vein that's returning blood to the heart now from the liver. We have the gallbladder over here. We have the common duct here, this one here. And then we also have the portal vein that is bringing blood from the GIT that's rich in nutrition and nutrients back to the liver for metabolism. And then we have the hepatic artery here that's draining the liver. And then we have the right lobe, which is bigger than the left lobe. And this is the diaphragm. So the liver kind of hangs on the diaphragm for support. And then so just a moment. Yeah, my slide wasn't moving. Yeah, now the liver is a very big organ, and it's almost 2 kgs, 1.2 to 1.5 kgs in humans. And it's attached to the diaphragm, as we've seen, and it's protected by the lower rib cage, and held in place by ligaments. So it's divided unequally, of course, into two lobes. The right one is almost 6 times larger than the left, and it's separated by a falciform ligament, which is visible in this particular diagram here. This one is the falciform ligament that's separating the right and the left lobe. So blood supply is by the hepatic artery, and we saw it, that is bringing blood to the liver, and by the portal vein. So this one brings 25% of the blood, rich in oxygen, and this one brings 75% of the blood rich in nutrients to the liver. Then it is drained by a network of veins that empty in the hepatic veins and then into the inferior vena cava and then back to the heart. Excretion starts at the bile canaliculi. This one is for the bile, and then it's drained by intrahepatic ducts, which fuse. After fusing, they form the left and the right hepatic ducts, which merge to form common hepatic duct. And this duct here, the common hepatic duct, also fuses with the cystic duct. This one is from the gallbladder to form the common bile duct, which now will drain the bile into the GIT that will be able to assist in digestion. So this is what we're talking about. We have the cystic duct here that's coming from the cyst, which is the gallbladder. We have the left and the right hepatic ducts that are joining to form the common hepatic duct. And the common hepatic duct joins with the cystic duct to form the common bile duct that will empty into the GIT. Now, microscopically, this is a microscopic anatomy or histology. Of course, has these lobules as the functional units that are independent. They work on their own. And each is hexagonal. You can see these the shapes of those particular lobules with portal triads at each corners. And each portal triad contains a hepatic artery, a portal vein, and a bile duct surrounded by the connective tissue. All these ones fuse to form the hepatic ducts that now empty the metabolic wastes into the bile into the bile duct and the common duct into the GIT to help in the process of food digestion. Now, the cell types that are found in the liver, we have the hepatocytes that are many. Hepatocytes are too many. There are too many. And then these ones here, and the functional units, the functional cells of the liver. And then we have the macrophages of the liver that are protective. They engulf bacteria and those sorts of things, which are called the Kupffer cells. These ones here. And the hepatocytes consist of 80% of all the cellular components. And then the Kupffer cells are composed of 20%. They make up 20% composition. Now, liver functions, if we need to understand how the liver, what happens when we have deranged liver functions, then we have to understand the work of the liver in the first place. And we know that liver has so many functions. Then the first one is to detoxify the blood and destruction of RBCs and formation of bile pigments, removable or excretion of drugs, alcohol, hormones, bilirubins, biotics, and conversion of ammonia to urea, then cholesterol into bile salts, which help in digestion. Then excretory function or excretory, it helps get rid of bilirubin, which is usually conjugated through the bilirubin is first, released by hemolysis, breakdown of RBCs. And we have the indirect bilirubin here, which is unconjugated, or it's just bound to albumin for it to be transported back to the liver now for conjugation to happen. And then once conjugation has happened, via the help of the uridyl phosphate, this one here, this salt, this molecule here, which is a glucuronide transferase, it helps in the conjugation of bilirubin into a water-soluble molecule that can now be excreted via the excretory system that you have. Could be via the kidneys, via the GIT, like that. But the indirect bilirubin cannot be excreted from the system because it is not water-soluble. It cannot be transported across those cellular membranes that help in the process of getting rid of wastes. Now, there is also a storage function of the liver, which is stores energy or glucose in the form of glycogen, also stores iron, also stores vitamins. These are fat soluble vitamins, or A, D, E, K, and then B12. And then those ones are the ones that are stored in the liver. They can be able to be used in times of starvation and those nutritional deficiencies. Another function is on metabolism, where there is glycolysis or breakdown of glycogen to release energy. Then there is protein metabolism. Then there is urea cycle, formation of urea. And then there is the amino acid metabolism, hormone synthesis, fatty acid breakdown or oxidation, then cholesterol synthesis. Now, synthetic functions of the liver include glucogenesis, making new glucose, glucogenolysis. This is the breakdown of glucose. This is a glycogenolysis, which is the breakdown of glycogen to release glucose. Then gluconeogenesis, which is the production of glucose from other molecules that are not carbohydrate in nature. It could be proteins, it could be fats, Then the TCA cycle to give us energy in form of ATP. Then digestion of lipids with the help of bile salts, as we have been able to highlight. Now, I've just highlighted here one of the role of the liver, which is the destruction of RBCs and doing away with those meta wastes that are coming because of RBC destruction. Now, after RBC destruction, we can have iron and proteins over here. Iron could be recycled or could be excreted, and then proteins are used in creation of other molecules and for structural building. Then we have heme, which is the component that's going to be broken down to release bilirubin. Bilirubin is usually conjugated to albumin, which is a transport molecule. And this part of bilirubin that is before it reaches the liver, it's called unconjugated bilirubin because it's just bound to albumin for transportation. Then once the unconjugated bilirubin reaches the liver, it is converted to the conjugated bilirubin, which is the direct bilirubin, by the uridyl diphosphate, this one here, glucuronide transferase, which is an enzyme that helps to convert the conjugated bilirubin into the conjugated form. And this bilirubin can be excreted via the GIT through urobilinogen, and most of it is excreted in the fecal matter, which makes the fecal matter actually brown. The stacobilin and stacobilinogen that are excreted by the feces. Other, like 20%, is excreted via the urinary tract system through urobilinogen that's converted to urobilin, and it is excreted through the urine, and we can be able to do a urine dipstick chemistry, and we can be able to detect the presence of that particular component of bilirubin. Now, the other function is, of course, in RBC destruction and formation of bile pigments. I think we can see that these are red blood cells, which are manufactured in the bone marrow, and they undergo phagocytosis, and hemoglobin is broken down through the function of the Kupffer cells, which can be able to break down phagocytose these RBCs. And then the heme is broken down to bilirubin and iron. Iron can be, recycled back into the bone marrow for use, or then the bilirubin enters into the liver for conjugation, and then can be excreted through the gut, the GIT, through the fecal matter. Then the globulin chains are broken down and they release amino acids because they are proteins. The globulins are proteins in nature. They have alpha, beta globulins, which are made up of amino acids, and they are broken down to release the amino acids that are used in further protein synthesis. Another function of the liver is, of course, protein metabolism. And we obtain food from the proteins that we eat, and they're broken down to amino acids through digestion. And then, or fasted state, this one here is for the extreme people who are fasting. You can also have the body through gluconeogenesis, stimulating the fat, the protein muscle to release amino acids that are going to be used in energy production. Then once these amino acids are here, they can be able to be used for hepatic proteins secretion. They can be secreted in form of albumin, secreted protein, clotting factors, and then lipoproteins. These are very beneficial function of the liver. These amino acids can also be, through gluconeogenesis, they can be able to help us get the energy that we need in those times of starvation. And then TCA to give us energy. Then urea cycle, and then to give us urea. This is our waste product. And then also can be converted to ketones and give us the ketone bodies in those times of inadequate respirations. Another function of the liver is on carbohydrate metabolism, which is just based on glucose control. Yeah. And it works with the help of some two very important hormones. And I'm going to highlight on glucagon here and insulin, which are hormones that are working in reverse to each other's functions. So that in case there is too much, we start with blood glucose. In case there is too much blood sugar levels, the body is going to secrete insulin that's going to convert that excess glucose into glycogen for storage. When there is too little glucose, the body is going to secrete glucagon, which is going to convert glycogen into glucose now for use in energy synthesis. Now, this is a negative positive feedback mechanism that exists so that when there is too much glucose, then the feedback loops are activated to stimulate which particular hormones to correct the high blood sugar or the low blood sugar levels as necessary. So if now we have low blood sugar level, just as I mentioned that there is little glucose here, glucagon is going to help in the conversion of glycogen back to glucose now when there is low blood sugar. The blue line is for glucagon activity, and the yellow line is for insulin activity, so that they are working like sort of antagonizing each other, so that they can bring about some homeostasis in the glucose metabolism and the glucose levels in the blood. This is just an expansion of the other image that we had released, shown there, where we have glucose coming, glycogen is over here. It can either come into the glucose ATP biosynthesis pathway here, and depending on the level of glucose, this monophosphate shunt always happens between glucose 1-phosphate and glucose 6-phosphate to help also balance between the two. And through these particular actions, they're going to give us glucose, which is going to be used for energy synthesis. When there is too little inadequate respiration, I mean, lactate is going to be formed. And amino acids can also be able to come here to form pyruvate, which through gluconeogenesis can give us back the glucose 6-phosphate, and which can be converted to glucose 1-phosphate, and the process is reversible here, like that. So now the glucose metabolism is controlled. Now, fat metabolism is also through cholesterol control. We have the foods that we ingest that are maybe rich in lipids. We have peripheral sources of lipids from fat deposits or adipocytes. Those guys who have very, 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 very big fat deposits could be under the skin or in the abdomen. They can be able to be broken down to help in, to help in the control. And that process is usually impaired. That's why there is too much deposit of fats and people get fat. the process of clearing that fat is inadequate, but the consumption or the process by which more fat is coming is too much. Now, lipids can also be in form of blood lipoproteins, and they come now into the liver for metabolism. They can either be esterified through esterification. They can be stored through triglycerides. They can be oxidatively acted upon to release acetyl coenzyme A, which is very important in the secretion of ATP energy. They can be converted to apolipoproteins and other forms of lipoproteins that are helping in the carrying of cholesterol and triglycerides away and towards the liver in the body. They can also be used in energy production. And once that happens, CO2 and water is released as a byproduct. And cholesterol is also part of lipids that is released into the bile, and this helps in the formation of bile salts that are going to be able to help in the digestion in the GIT. The excretory part of the liver is diverse. The liver is like a factory helping us clean the blood. And when we have, of course, dysfunctional liver, and then all these ones are going to be impaired. We have cleaning of products. We have personal care products that are, cleaned also in the liver. Air pollution cleaned in the liver. Air fresheners, like contaminants, cleaned here. Alcohol, food additives, medications, water pollution, pesticides, all these things are coming to the liver. And for the guys that like alcohol, and then you can know that there is a problem that you're causing to your liver if you're doing it in excessive consumption. All right, and then the liver also works to detoxify the body, to get rid of the toxins. Yeah, and then we have the fat-soluble toxins here that are excreted through the help of cytochrome P50 enzymes. We have water-soluble wastes here that are excreted through these conjugational pathways over here. So phase one involves oxidation, reduction, hydrolysis, hydration, dehalogenation or removal of those halogens. And these ones are needed in that particular process. And then the water-soluble toxins, we have sulfation, glucuronidation, which is just the conjugation, then glutathione conjugation, acetylation, and then amino acid conjugation, and then methylation. All those ones are pathways through which wastes are excreted in the liver. Then these wastes are eliminated in urine, bile, and stool. And then these ones are the nutrients that are needed in that particular process to be facilitated. Now, on the functions of the liver, now this is liver function tests. We can be able to do an assessment for jaundice. And we need to understand that this is one of the most common indications for liver functions requisition. And jaundice it comes from the word jaune, which means yellow in French. And here the liver profile that we're concentrating on is going to be bilirubin levels. So we know that jaundice will arise because of too much bilirubin accumulation in the body, and it is classified in three forms. It could be prehepatic. Prehepatic, as I mentioned, this is just the unconjugated bilirubin, right? The bilirubin that has just been broken down, that has just been released from RBCs after they've been hemolyzed. It's only bound to albumin for transportation. Otherwise, it will not be able to reach the liver. Then when there is too much unconjugated bilirubin or the indirect bilirubin, then this means that we are dealing with a prehepatic issue. Prehepatic issues could be anything in the peripheral circulation, and they include maybe increased hemolysis, maybe even after post-transfusion reaction that is leading to hemolysis. If there is hemolysis in the peripheral blood, it will lead to too much unconjugated bilirubin, because this bilirubin has not yet reached the liver for conjugation. Then now we go to the hepatic function, where this is now intrinsic to the liver itself. And it also includes such things such as neonatal or physiologic jaundice. We've seen this one in those babies that are born premature. In the Gilbert disease or Crigler-Najjar syndrome, these are all complicated by unconjugated bilirubin. In children, the uridyl diphosphate, that one, the glucuronyl transferase enzyme is not yet fully formed, so the conjugation process is impaired. You know, we are going to have too much unconjugated bilirubin in circulation because of the way the children are, those neonates. Then the Dublin-Johnson syndrome and the Rotor syndrome, this one there is too much conjugated bilirubin. So there might be hyperfunctionality of the liver, which is conjugating too much bilirubin, of course, in response to some pathological condition. Then there is posthepatic, which is after the liver. Now, posthepatic is just abnormalities that are happening after the blood has gone through the liver, which could be, you know, the biliary system, which is the main one. It can either be blocked or obstructed, or it could be having some sort of pathological issues with the biliary system or the gallbladder. Now, that particular pathway leads to too much conjugated bilirubin. You'll be able to see that there is too much conjugated bilirubin because it has already gone through the liver, it's been conjugated, and now there is just nowhere it's going because of the obstruction, and it's going to be too much buildup in the body. So in all these cases, most of the time you'll have increased total bilirubin counts, but now the unconjugated and the conjugated fractions will be different depending on now where you're handling on either of those particular places. Just an explanation of what I've been highlighting, that prehepatic issues include such things as transfusion reactions, which leads to hemolysis, sickle cell anemia, thalassemia, autoimmune diseases that increase hemolysis levels, and you'll be able to get a lot of indirect bilirubin here. Then we go to hepatic issues such as hepatitis, cancer, cirrhosis, congenital disorders, and drugs that are affecting the liver. You'll be able to get both unconjugated and conjugated elevated in the total as well. Posthepatic, mostly the conjugated bilirubin, where we have gallstones, inflammation, scar tissue, or tumors that block the flow of bile into the intestines or out of the liver, and you'll be able to get that particular issue there. Now, these are the reference values as adopted from the Bishop's, clinical chemistry correlation principles and correlations. This one is adult bilirubin, and then pediatric bilirubins, and the premature babies and the or infants, and then the full-time babies. These are the reference values that you might be able to refer to maybe later on in your practice, or you're already doing that. I'm not going to belabor on it. Now, alterations of these functions will involve several things. We also have cirrhosis, apart from jaundice. Cirrhosis is just the scarring of the liver tissue, It's normally very, very soft, but when it is scarring up or forming sort of hardening and blocking, hardening in itself will lead to blockage of vessels and such kinds of things, which is a problem in itself. And this results in fatigue, nausea, unintended weight loss, jaundice, bleeding from the GIT, intense itching. Those guys with a lot of bilirubin have a lot of itching because of the bilirubin levels. And then ascites, which is also ascites is the accumulation of fluid in the abdomen, and you can be able to see those cases happen in people with cirrhosis. Then it is caused by too much alcoholism, chronic hepatitis C, hepatitis B, hepatitis D, virus infection, which we're going to also to look at as part of the liver function tests, autoimmune hepatitis, then inherited disorders such as the Wilson disease, hemochromatosis, and the galactosemias, neonatal non-alcoholic steatohepatitis, which is leads to blocked bile ducts. This is too much fats in people who are not having alcoholic liver. Yeah, alcoholic liver. This is an alcoholic liver, but there is too much fat deposits, which lead to blockage of the bile ducts. And then also drugs are involved, toxins and infections in people with the non-alcoholic liver cirrhosis. So it could be due to all those conditions here. So when you hear of cirrhosis, it's not liver cancer, it's just some sort of chronic liver condition that is leading to the scarring of the liver tissue. Then now we have tumors, which will be, they're not mostly metastatic or the origin from elsewhere, and they're dislodging in the liver because of the nature of the liver. It's receiving blood from all over the body for detoxification and all those functions. So most of the tumors will be able to metastasize to the liver. And most of the liver cancers, 90 to 95% of them are metastatic, not primary. And primary could be benign, such as hepatocellular adenoma or hemangioma, or malignant, such as hepatocellular carcinoma or HCC, hepatocarcinoma or hepatoma. Those ones are malignant forms of tumors, and they can be told apart through maybe, fine needle aspirate or core biopsies. Someone can be able to look at them and tell that they are not they're tumors like that. So these are all things that are going to be able to alter the liver functions. And we are still going to look at some more drug or alcohol-induced alterations in liver function. This one occurs via immune-mediated injury to hepatocytes. And alcohol metabolism happens entirely in the liver. This one, I don't know, it's not a warning really, but if you love your liver and if you want it to work very well, then you might want to reduce the alcohol consumption. You might want to reduce the alcohol consumption and help the liver now work against all the other toxins that could be in the body. Imagine, we're having so many environmental toxins that are already putting pressure on the liver. And then you introduce some more out of leisure, yeah. And then you maybe may make it the situation that's already bad to be worse. And it now strains the liver in its functionality like that. Now, alcohol metabolism involves the use of the enzyme alcohol, dehydrogenase and acetaldehyde dehydrogenase, which convert alcohol to acetaldehydes, which is a form that can be converted to acetate here. And this acetate is further oxidized to water and carbon dioxide that now may be able to, be excreted. Or it can also enter tricarboxylic or the citric acid cycle or the tricarboxylic acid cycle to help release energy. Acetate is a molecule that can be converted through acetyl coenzyme A, and it can also help in the production of energy. So you might want to understand a little bit of that so that you understand how alcoholism will be able to bring about the alteration in liver functions. Then, of course, excessive intake of alcohol leads to fatty liver and alcoholic hepatitis and alcoholic cirrhosis, which are very, very complicated things to handle, Then autoimmune conditions also affect the liver. They alter the liver functions. This is due to the defective suppressor T, which leads to synthesis of antibodies against hepatocytes surface antigens. Now, such conditions may include things such as chronic active hepatitis, which we're going to have increased antinuclear antibodies in those cases, double-stranded DNA in systemic lupus erythematosus. Then we have the smooth muscle antibodies in chronic active hepatitis, antimitochondrial antibodies in primary biliary cirrhosis. We have acylglycoprotein antibodies where we have too much expression of acylglycoprotein receptor on hepatocytes. Then increase in immunoglobulins, which are mostly IgG and IgM, because IgE, IgD, IgA, and IgE are very, very limited or little, and most antibodies are usually IgM and IgG in nature. And this one, because of too many globulins, which are IgG, IgM, will lead to the reduced albumin and globulin ratio. By the way, albumin to globulin ratio is just a way of measuring how the balance between the proteins, the components of the proteins, which are either albumin or globulins, like that. And too much of this might want to ring a bell, so that you may want to analyze why there is too much globulins in the body, why there is too much immunoglobulins. There could be a problem altogether, or in autoimmune conditions. Now, how are these ones beneficial? The liver function tests, they assess the degree of parenchymal cell damage, differentiate types of liver diseases, such as jaundice, hepatitis, obstructive, cirrhosis, or hepatoma. You can be able to tell by just looking at the LFTs, the way it's behaving in jaundice. You look at the bilirubins. In hepatitis, you want to look at the enzymes that are going to be elevated in those cases, and in all those kind of situations. Then judge the prognosis of a patient, and then evaluate the response to treatment, e.g. like therapy with statins, which are hepatotoxic, so you might want to check for hepatotoxicity. And then therapy for coagulation disorders, and you might want to do the liver functions and even the clotting factors to help analyze whether the liver is doing the work properly, like that. Now, the enzymes themselves, we have enzymes and then those proteins and bilirubins. The correlated enzymes are the SGPT and SGOT. SGPT is the serum glutamyl or the serum glutamate and pyruvate transferase, or the serum glutarate aspartate or oxaloacetate transferase, SGOT, which increase in different conditions. So SGPT is increased in liver diseases, can also be increased in muscle conditions and kidney diseases, and infective hepatitis, primary and secondary hepatic cancer, and in obstructive jaundice. Well, we can have values going to 200 to 300 IU per liter, or units per liter. Myocardial infarction, my friends, leads to an increase in SGOT. So if you're doing your liver functions and you are seeing that only SGOT or AST is elevated, then you are not dealing with a liver condition. You are dealing with something else. It could be a myocardial infarction, or this is what we call the heart attack. Those people who are having heart attacks or those heart conditions will have very high SGOTs, and you will not be able to confuse that with the LFTs. If other enzymes are normal, you'll just conclude that this one is because of some other reason. It could be a myocardial infarction, but not a hepatic condition altogether. So these are the principles of SGOT assays and SGPT assays, which lead to the formation of the pyruvate, this one here. And pyruvate is further hydrolyzed to form pyruvic acid, and this one is proportional to the quantity of SGPT and SGOT in the blood. Then sustained increase in plasma transaminases for more than 6 months indicates a chronic liver disease. So acute forms will go up to 6 months, then chronic liver diseases will pick up from there. Above 6 months, continuous elevation in those particular transaminases. Now, SGPT is also raised in acute hepatitis, which you can find values going up to 1,000 and more. It can be also in hepatic diseases. You find that there is more SGPT than SGOT, because this is influenced by other things, as I mentioned, the heart muscles also secrete SGOT. Then the degree of elevation of SGT reflects the extent of hepatocellular damage. So this one is very specific to the liver. Then lowering of transaminases indicate recovery, but sudden fall from very high may also indicate poor prognosis because the liver might now failing altogether. So in alcoholic liver disease, we have more SGOT as compared to SGPT. And then we have, this one is in severe cases. This one's supposed to be normal. And when it's above 2, the ratio is above SGOT to, SGPT is above 2, then that's an abnormal. Then mild elevation in SGPT's correlation with mild liver disease. So the more the imbalance in this particular ratio, the worse the situation. So you might want to correlate the SGPT always with SGOT and not to interpret them independently like that. So then the ratio is usually around 0.8 to 1, the ratio of SGOT to SGPT, or 1, they're supposed to be equal. So if there is too much of this or too much of this, the ratio will be reversed, and you might want to correlate with the patient's history and other muscle injuries to help now know why it's like that. So if this ratio is more than 2, we are dealing with alcoholic hepatitis, we are dealing with hepatic cirrhosis, we are dealing with non-alcoholic steatohepatitis, too much cholesterol, we are dealing with liver metastasis of cancer, we are dealing with myocardial infarction because of too much of this, we are dealing with erythromycin treatment, which now the liver reacts like that. Low SGOT SGPT ratio means that there is too much SGPT, which is ALT. This one is present in acute hepatocellular injury and toxic exposures and extrahepatic obstruction or cholestasis. Too much SGPT will be present in cholestasis. Now, the liver diseases and the conditions the transaminases affected, we have the parenchymal liver cell damage leads to increased ALT or SGPT and AST or SGOT. Viral or toxic hepatitis leads to, increased ALT and AST and reversal of that particular ratio. Instead of AST being more than this, the ratio is reversed like that. Then cirrhosis, increase in plasma AST, where cytoplasmic and mitochondrial membrane are damaged, of course. Then chronic hepatitis, which is now more than 6 months, ALT, AST are normal or slightly increased. Cholestasis, we have high plasma ALT or serum ALT as compared to AST. Alcoholic hepatitis, we have high ALT as compared to AST. The ratio is reversed. Then cholestasis, we have ALP and DGT increased in cholestasis, as we're going to explain in the next slides. So in obstructive issues where there is cholestasis, in gallstones and those kinds of conditions, there is the obstruction of bile flow. And this stimulates the liver to continue secreting a lot of ALP, and it will be detected like that. Too much ALP indicates a post-hepatic issue, which is mostly cholestatic. Now, progressive increase in ALT is characteristic of malignancy, which you might want to analyze. It has 6 isoenzymes that I'm not going to mention. And then hepatic isoenzymes, of course, they originate from the bile canaliculi and then sinusoidal surfaces of hepatocytes, which are in these ones over here that I'm not going to mention about the isoenzyme. Just know that ALP is elevated in post-hepatic conditions, more so cholestasis or the blockage of the bile systems. Now, this is the principle of ALP, analysis, and this particular brown color after you've done your the chemistry during your reagent mixing, this brown color is proportional to the ALP concentration in the system, and the normal range will be from around 40 to 120, and increased, of course, it's increased in obstructive jaundice and hepatitis, and also in hepatomas. And this also is, coupled with the increase in conjugated bilirubin. Conjugated bilirubin is a post-hepatic condition, which means that this bilirubin has already gone through the liver and has gotten conjugated. GGT is specific to the liver, and it's predominantly located in the endoplasmic reticulum of cells of the hepatobiliary tract. The normal is 10 to 30 units per liter, increase in cholestasis and post-hepatic obstruction, and also in chronic alcoholism, like that. GGT is also increased even when could be increased even when the other LFTs are within normal ranges in alcoholics, and also as coupled up with the reversed SGOT SGPT ratio. Now, in liver diseases, GGT elevation parallels that of ALP and is sensitive to biliary tract disease. So post-hepatic issues such as cholestasis, or those blockage of the biliary system, which is the main post-hepatic issue, GGT will correlate with ALP because all of them will be high. And you might want to correlate them like that in your results as you're releasing them. Conditions that are associated with high GGT are like chronic alcoholism, infective hepatitis, myocardial infarction, renal failure, chronic obstructive pulmonary disease, diabetes mellitus, and this one is non-alcoholic steatohepatitis for those guys with too much cholesterol now in the body. So some normal reference levels for SGPT is 10 to 35, SGOT are below 35, ALP 10 to 25, 125, but different labs will have different levels because people usually verify these methods in their own labs, and sometimes people can also use their own populations to derive the reference values. So, you might have different reference values for those particular cases. Before we finish on the left, I wanted to mention on hepatitis viruses. These ones also influence the functionality of the liver, and it's very, very common to find hepatitis A, for example, which its epidemiology is oral fecal, fecal oral. Fecal oral routes. We will be able to obtain this one from the foods you're consuming, whether they're contaminated, and the water also. And you can be able to measure this one through anti-hepatitis A, IgM. IgM usually indicates acute infections. If you want to do some diagnostics, you don't want to do IgG. IgG is long-term, but IgM is acute infection. So you do an anti-hepatitis A virus IgM. This one will be able to be diagnostic of hepatitis A condition, or you can do the antigen in stool, the hepatitis A antigen in stool. Hepatitis B acute, we can be able to do hepatitis B surface antigen. We can also do the antigen here, or the co-IgM. IgM is going to dominate here because IgG is long-term. It might indicate an infection, a previous infection, not a current infection that the patient is suffering from. Then hepatitis B is obtained from percutaneously or maybe through needle pricks, sexual or perinatal sources. Then chronic hepatitis B, we can be able to do the surface antigen, we can be able to do the envelope antigen. And then we can also be able to do the hepatitis B virus DNA viral load. Then this is the source. Hepatitis C, we can be able to do that through anti-hepatitis C IgM as well, or antibodies. We can also do hepatitis C virus RNA, and these are the sources. And delta hepatitis D only occurs in the presence of hepatitis B, and this is the sources. And we can be able to do the anti-D IgM as well, as well as doing the hepatitis B surface antigen. So you'll not find D alone. D is always in presence with hepatitis B. E, we do the IgM and IgG. This one is for the previous exposures, and it's also waterborne. You obtain the hepatitis E from the water. Now, hepatitis B surface antigen helps in diagnosis of acute infection or persistent infection also after 6 months, which is chronic hepatitis. The envelope is indicative of active viral replication, and it indicates that the virus is at its high infectivity stage because of too much envelope antigen. Now, the surface antigen, these are the antibodies against the hepatitis B surface antigen indicates immunity. Those guys who have received the jabs for hepatitis B virus. Anti-hepatitis E antibody also means that this is a resolution of an acute infection because E is indicative of active replication. So if we form antibodies against E antigen, then this one is a resolving infection. The body is fighting against this particular infection. Anti-hepatitis B co-IgM is for acute infection as well, where you see IgM, acute infections like that. And then DNA used for viral load assessment. These curves just describe the behavior of hepatitis, over time. And we have IgG. We have, this one is the immunoglobulin G after exposure to hepatic viruses. This one after like 2 weeks, 3 weeks, I mean, the IgG levels are going to rise like that. And then they're going to remain high like that because IgG is dependent on the memory of those particular immune exposures. But IgM will rise after 6 weeks, it's at the maximum, then will fall. So if you're doing IgM after 12 weeks of exposure, you might find a negative ELISA because this person has already remitted, has already come back to normal. And this one here will remain high like that. The same with the others, as I've just been explaining. Hepatitis B surface antigen will remain. In acute illness, all of these will be high. But in chronic illnesses, we have hepatitis B surface antigen remaining, envelope antigen will reduce, and then the core antigen as well will be able to reduce, as we're going to see. So this is hepatitis B surface antigen. You can see this one here, the envelope antigen here reducing after the acute infection, and then the anti-E antibodies now will form to indicate that this one is an immune reaction to that particular infection. So wherever there is an acute infection, we're going to have surface antigens, we're going to have the envelope antigens, we're going to have the core antigens. When there is delay, or maybe this one is a past exposure, we're going to have the surface antigen remaining, and the envelope antigen is going to reduce because there is no active replication of the virus. So these are the things that we need also to keep in mind as we do the liver function test, and the hepatitis viruses is part of that particular panel that we need to understand about it. Now, as we classify the liver functions, the liver, the LFTs, we can be able to classify them as biochemical or clinical. And this I've just been able to break down so that we can be able to remember that group 1 is based on the excretory function of the liver, where we have serum bilirubin, total and conjugated, both of them. And then we have the bilirubin, which is indicator of icteric index. This one is the deposits of those particular bilirubin component, molecules in the body. Then we have urine bilirubin and bile salts, indicative of the excretory function. You have the urine urobilinogen and the fecal stacobilinogen, also the excretory function, and then urine urobilin and urine fecal stacobilin function of the excretory function of the liver. So these are the things that we need to remember. And then also the enzymatic panel or the biomarker of liver injury are the enzymes now. Most of the enzymes will be able to indicate the actual liver injury. We have alkaline phosphatase, GGT, serum glutamate pyruvate transamination, serum GOT, glutamate oxalate transaminase, glutamyl transferase, and then choline esterase. Those ones will be elevated in liver injury. The synthetic power, we have plasma proteins, including things such as fibrin itself, or not fibrin, fibrinogen. Fibrin is the clot. Fibrinogen is the protein that's circulating in the blood. So we have the total protein, albumin, globulin, serum, albumin, globulin ratio, and fibrinogen. This is the secretory, the synthetic power of the liver. We have amino acids which are also produced in the liver and they are circulating in the blood and urine. We have alpha fetoprotein that is could be a cancer marker. When there is too much synthesis of it, you might want to find out what type of liver condition is causing that. Then ferritin, the storage form of iron, is also the synthetic forms part of the synthetic power of the liver. Then the test for coagulation, of course, here include the prothrombin time, which will be also indicating whether there is enough excretion of the clotting factors or not, and it's a function of the liver. Now, on the clinical side, we have markers of hepatocellular injury, and those are the enzymes. Marker of cholestasis, these ones, cholestasis, post-hepatic, ALP. You think of cholestatic, think of ALP, and then GGT. Hepatic issues, think of SGPT and SGOT, which could also be elevated in myocardial infarction. So those are some of the things that I wanted to highlight in this particular presentation, as we maybe have some section or some time for answers or inquiries, questions, inputs in relation to liver function tests. And at this particular juncture, I'd want to return the mantle back to the the moderator for picking up from there. Thank you so much. Frederick, I think back to you. Yes, Frederick, if you can be able to hear me, I think it's a time that you can be able to pick up so that we can look at some of the inputs that the participants are having, or maybe questions, inquiries, or additions.
Thank you so much, Cosmas. It was quite a wonderful presentation. And I can see members here have really have interacted with the presentation. And they're saying it was very informative. Benjamin Munyao saying very nice from Coast. And I can also read from Nicholas Kiprono saying nice presentation. And many of you found time to tune in and also to just follow the presentation. Mishek Masika is saying, learning on this informative topic from Kitui County, Kitui South. Thank you so much, Masika. Mildred, I'm learning from Nairobi. This is very good. And I believe that all of us have found time to just follow through the presentation, and we have learned something. So we will get to the Q&A section. And maybe if you are together with me up to this point, you can go to the reactions and just send in that to show that we are together. Otherwise, we will read a few questions from you. And even if you have some questions right now, you can go to the Q&A section. You can type in your question. We shall be able to read it and discuss. If you want to maybe make a verbal comment, you can always just indicate so that we can unmute you, and you can also ask or you can react as necessary. Otherwise, I'll read the first question from Calvin's Okech. He's saying, I had a patient who was complaining of a constipated stomach with abdominal pain and general weakness. So when I did stool analysis macroscopically, when I did stool analysis microscopically, the stool was semi-formed and yellowish in color. And microscopically, I saw yellowish square-formed elements and no ova or cysts. Could it be a problem that started in the liver that created the problem? Okay. Then he asks, what could be the remedy? I don't know whether Cosmas, you have any insights on this?
Maybe I don't know. You said this Meshach or someone, eh?
Yes,
Who
Calvin's.
asked the question? Calvin's.
Yes.
Now, we have seen that the GIT is one of the actually most of the bilirubins that is broken down in the liver is excreted through the GIT. So the deposits, the yellowish deposits might just be bilirubin deposits, which could indicate the too much of it in the body. Now maybe, but that's also the normal excretion pathway for the bilirubin. So you'd want to relate. You don't want to report conclusively that this is a problem with the liver. You might want to correlate with the liver function enzymes, especially the bilirubin themselves, and then confirm that it's not a problem. Otherwise, it's a normal physiological excretory pathway for the excess bilirubin in form of sacchobilinogen in the stool.
Very well, thank you for that. I think I can go to the next one. This is from Joseph Tanui. Saying, what is the most common complication of liver disease? And then, does ascites mean end stage? Thank you, Joseph, for the questions.
The most common complication of liver disease.
The most common complication, yes.
The most common complication of liver disease.
Yes.
I think is liver failure itself, where we have the liver now stopping to function as it's supposed to do. And this one will create a lot of other problems now because of the way we discussed the functions of the liver in the presentation. So if it's not working normally, when there is liver failure, then that's going to be a complication. Ascites is most commonly present due to cirrhosis. And we have already handled a topic on ascites, and it forms just because of the imbalance in those, albumin gradients between the tissue fluid and the blood circulation. And it might not mean end stage per se, because unless you correlate, it's always good to correlate. You don't rely on one indicator to confirm that this is an end stage something. So if you're seeing ascites and you're seeing elevated liver enzymes, you might also do an imaging of the liver to see how it is, and also correlate with other things, because there are other things that can cause ascites as well, such as portal hypertension, such as, in fact, chronic cardiac failure or congestive cardiac failure. I mean, those are some of the things related to ascites. So you might want to correlate with a lot of things for you to conclude that this is an ascites because end stage liver disease or something like that.
Very well, thank you for that. So someone is asking, as an anonymous attendee, can LFTs be used to diagnose fatty liver?
LFTs will be helpful. It will be helpful, but not, you don't rely on LFTs alone. Imaging is very important. And apart from imaging, we also have the histology part of it. There's so many diagnostic modalities to this. You can do imaging, You can do the liver enzymes, and then you can do the histology. Histology, in fact, is the best. You can be able to see the fatty liver on the slides. So it's not the liver enzymes that are going to tell you that these are fatty liver. It's imaging and microscopy of the actual liver tissue to tell the nature of the cells, which are usually filled with fat, droplets in fatty liver cases.
Thank you. So to all the participants, Swale, I can see you raised your hand, and I'll allow you to either react to this presentation. So I'm going to allow you to talk, ensure your background noise is, ensure you don't have any background noise, and then you can proceed. So Swale, I welcome.
Yes, good afternoon.
Good afternoon.
I wanted to know if there is any relationship between the green stool secreted by neonates and liver disease. Thank you.
Yeah, there is a correlation. I don't know, I didn't get your name, but there's a correlation. Usually the bilirubin is secreted in the form of stacobilinogen in the GIT, and it's worked on by the GIT microbiome or the bacteria, the normal flora of the GIT, to convert it to stacobilin that will be forming the yellow stuff in stool. So in neonates, these guys don't have formed microbiome of the GIT, so we're not going to have enough conversion of stacobilinogen to stacobilin. So you might see the greenish sort of appearance in the stool of these particular neonates. Yeah, back to you, Frederick.
Thank you. Swale, thank you. I know Swale is also an expert around this area. And yeah, and maybe his insights are also just welcomed. But thank you.
Perhaps he can also chip in. If there is something, maybe he can also chip in and enlighten us also regarding the same question.
Swale, back to you. Do you have anything?
No. It's okay. It's okay. Thank you.
Okay,
All right.
very good. So to our participants, you are free to also make your comments. If you want to speak, you can always just raise your hand. I will unmute you and you can go ahead to prosecute what you think you need to let the class know. So this continues to be very interactive. And in case you have something that you feel you need to comment, go ahead to comment or to ask your question. Otherwise, I will read the next question from an anonymous attendee, and is asking, can you correlate LFTs with UECs? Okay.
That's a very wide question. I don't know how to answer that one in a in a brief way. I don't know how we can be able to correlate, because these ones are separate functional assessment of two different organs. But there are some conditions that affect both the liver and the kidneys. So perhaps if there is such kind of an interaction in the specific patients, you will be able to correlate the two. But there is no direct correlation, because there are different organs that are working independently to do different works. So I think that one can be approached from that angle, I think.
Okay, great. So maybe I'll take the next couple of questions, and this is from. Okay, I've read your comment, Rogers, and maybe I can just read to the participants here. And he's saying, in regard to the ranges, he's saying the normal ranges, I think it depends with the model of the machine. Okay, Rogers, thank you for that. So
Yeah,
anonymous attendees asking, what's
I think we have lost you, Frederick. Hello, Frederick. Maybe the anonymous attendee can be able to unmute and maybe ask the question verbally, because Frederick might be having an issue with his audio. Frederick?
Yeah, thank you for that. I'll bring in the next question. This is from anonymous attendee. Is ascites associated with HIV patients? Okay.
When you look at the synthesis of ascites, it is not. It is not. It is related to differences in the components of the blood. I mean, the protein components of the blood and the tissue. You know, the fluid components, especially the proteins, albumin specifically. And this is usually affected by conditions that are affecting the linings of those particular membranes that are separating the extracellular, that tissue fluid and the circulatory system. And this one will lead to ascites, but not directly linked to HIV, unless maybe HIV itself is causing a hepatic issue, maybe due to sometimes these antiretrovirals affect the functionality of the liver. So if they're affecting the liver, then it's going to manifest as an ascites because of the effects of HIV on the liver, and then manifesting as ascites, but not directly because of the virus itself. So it has to have undergone some kind of a physical injury. There has to be a physical injury to the membranes, or some blockage in the fluid passage, or some discrepancy in the protein content of the two fluids to cause ascites, but not directly like that. Yeah.
Thank you so much. Thank you. I can see a lot of you are saying that when you need a presentation on UECs, I think we have taken note, and you look out or watch out to our posters and webinar alerts. We shall broadcast it soon. Thank you for that comment. So I can still see a question here, and maybe it can be the last one, unless this is from is Veronica Ndolo. Kindly explain hepatitis B profile. That is hepatitis B surface antigen, anti-HBC, and anti-HBS.
Okay. Hepatitis B, we know that's a virus. It's a DNA virus. This profile is just trying to assess the different components of or the different aspects of the cell itself, or not the cell, the virus itself. We have the envelope, we have the core antibody, not the antibody, we have the envelope, we have the surface, we have the core, and we have the DNA itself. Yeah. So these components are going to be elevated in different aspects, because hepatitis can have an acute onset, an acute illness, or a chronic illness. Now, in acute illnesses, you're going to have a lot of viral replication, and active viral replication is indicated by a lot of envelope antigens, or envelope proteins of the virus. So if you do your panel and you are seeing that there is too much envelope, of course there are ELISA platforms that can be able to quantify these particular things. you do an ELISA and you are doing an IgM against the envelope antigens. If it's too much, then you are going to conclude that this is an acute hepatitis. Even the core antigen as well. So the antibodies against the core and the envelope, those are for acute markers. Surface could be acute and chronic, and then the viral DNA itself could be acute, could be viral load assessment, when you're doing the PCR for actual quantification of the virus. So you look at the virus structure and the different components of what is present in acute infection and components that are present in chronic infections. And if you're doing ELISAs, if you want to see the past infection for hepatitis B or exposures, you're going to do IgG. You want to do the active infection, you're going to do the IgM like that. So I think that's basically what the panel is all about, hepatitis B alone.
Thank you so much. And also we shall organize a session for that. For those of you who are interested to have more information or for more interactive learning around that area, we shall have more sessions. Otherwise, team, I think we have come to the very end of today's presentation. I'm hoping that you have enjoyed and you have also learned. It was quite an interactive session. And at this point, in case you have never attended any of our webinars, kindly find the link on the chat box and ensure that you join our WhatsApp group so that you can get all our updates. Otherwise, this session was KMLTB accredited, and as a result, it will attract 3 CPD points for all eligible participants. And you should be able to check if it has reflected on your KMLTB portal within 24 hours. Once again, I repeat that this session is KMLTB accredited, and as a result, it will attract 3 CPD points that we will upload in the next 24 hours. So in case we have a problem with your registration details, we usually send an email. Ensure that you respond to that email correcting your details to read the correct details. Otherwise, we are organizing a dinner on the 28th of this month for all medical lab professionals at Pride Inn Hotel, Westlands. We will converge there all medical lab professionals, all the stakeholders, and I want to take this earliest opportunity to welcome you. You can find the posters all over, and we have an offer for an early bird of 3,500. So you can find time, join the rest of us on the 28th of November at Pride Inn Hotel, Westlands. Otherwise, thank you so much. And over to you, Cosmas, for your final word as we end this.
Okay, thank you so much, Frederick. It's always a pleasure to engage with all of you at LMSK. And as much as we release figures and values in the lab, we should also understand what they mean. And this is the reason why we are having these kinds of sessions. And it's just some sort of an empowering. So feel empowered, pick up those roles in those departments, those labs that you're working, and make yourself visible in the healthcare team so that you can feel appreciated and you can also feel as part of the team that's actually taking care of the patients, if you are doing it from the back door of your labs. So that's all from me. And thank you for tuning in, and have a good evening.
Thank you. And to everyone, have an enjoyable evening. See you next time.
All right. Bye-bye.